Good evening or late afternoon, depending on where everyone is joining from. I'm so excited that everyone could be here today to join us for our Q&A with Dr. Oro. Really excited that everyone could submit some really fantastic questions. And just Dr. Oro, thank you so much for taking the time to answer this and really just to help kind of unify the Chiari community and bring everyone together and really just clarify some questions I'm sure a lot of people might be too afraid or anxious to ask and just really would like some clarity on. So I really appreciate what you're doing for everyone today. I just wanted to kind of open it before we get to that and see if there was anything you wanted to start with by for anyone maybe who doesn't really have a great understanding about what Chiari malformation is, or just in general, an explanation of what to expect when they hear about Chiari malformation. Anything you'd like to start with?
Sure. Well, in the late 1800s in Prague, Czechoslovakia, a doctor named Hans Chiari noted this malformation in the back of the skull. I hate to say that these were post-mortem evaluations. Obviously, there was no scanning at that time possible. So this malformation took Dr. Chiari's name. And excuse me. The bottom line is that we need spinal fluid to flow easily from the brain cavities, what are called the ventricles within the center of the brain, around the brain, the fluid that kind of suspends the brain and cushions the brain. But that fluid also flows down into our spinal canal. It gets taken up by what are called arachnoid granulations. It basically gets taken up by the blood again. And this constant circulation that we have of spinal fluid. So, you know, you live near a lake and you've got a stream and you're used to seeing that stream flow easily, but then unfortunately a bridge falls on it or whatever, and we have a restriction. The lake maybe swells and floods the nearby homes because of that restriction. So the flow of spinal fluid from around the brain to the spinal canal is very crucial. So that means that the hole at the bottom of our skull, where the brain connects to the spinal cord, needs to be open. If you cough and sneeze, you need to be able to flow some of that spinal fluid. It needs to be open. So Chiari noted that the lower part of the cerebellum, which has an odd name, it's called the tonsils of the cerebellum. I remember, as an aside, I remember a husband that was sitting there patiently as I was talking to the lady with Chiari. He finally said, whoa, 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 this is not about her tonsils. What are we doing with her tonsils, you know? And I said, no, you know, the lower part of the cerebellum, if you look at it, it sort of looks like two nubbins, somewhat round. And so it got the name of the cerebellar tonsils. Well, Hans Chiari and others later, of course, noted that if those cerebellar tonsils start plugging off the hole at the top of the spinal canal, we're going to have increasing symptoms. Let's say it's tight enough, if you cough and sneeze, your head's going to feel like it blows up. Because normally if we cough and sneeze, that spinal fluid needs to flow down, the spinal canal expands, and we get a release of the pressure, if you will. The thing that happens, though, over time is that not only is it crowding and causing headaches, but it's starting to pinch the spinal cord and squeeze it, and the lower brain stem. And these are highly vital areas: our cardiac, our breathing, feeling arms and legs, movement of arms and legs. There's so many functions in that area that if it starts getting squashed, if you will, then people are going to have symptoms from that. And we've talked about the leading symptom, which is the headache, which is worse with cough headache. As an aside, to try to sort out, are people having problems from Chiari? Is there headache from Chiari? Or is it for many other things that could occur? I might ask someone, and this is more common in women than men, but I might ask, what do you do when you look up at the upper kitchen cabinets? And it's not unusual to hear, oh, I don't do that. Oh, I asked my daughter to do it. I asked my husband to do it, or I step back and look up. Because when we look up at the upper cabinets, we're crowding it further and we're having a greater headache. So the neurosurgeon and neurologist evaluating is looking for these clues. Now we can understand that something mechanical is going on that's increasing the headache in this particular individual, if you will. But again, since it's squeezing the lower brainstem, what I call the most vital area in the universe that we know of today, because it keeps us alive. It runs so many nerves, arms and leg functions. I mean, it's neurocentral, I guess is the best way to put it. So depending on the amount of hang down, the shape of the crowding, et cetera, different circuits in that area can start being affected. And so folks come in and they have a general group of symptoms, but not everybody's going to have the same thing because their pressures can be very different. It might be they only have a headache. It might be they have terrible dizziness, ringing in their ears, balance problems, et cetera. So that gives us an idea of what the Chiari malformation is: a crowding at the lower brainstem, cardiac functions, breathing functions, upper spinal cord, all the sensory fibers that are coming up, all the motor fibers. By motor, I mean that allow us to move things properly. Things are getting pinched off. So for the specialist that is listening to the history, we're listening for clues. And one of the questions early on, and maybe I'll just go to that one, is, well, wait a minute, can't an acoustic neuroma cause some of the same symptoms? And the answer is it can cause some of the same symptoms. An acoustic neuroma growing deep inside our ear in the skull base can affect the balance nerve, can affect the hearing. So you can be losing hearing, you can have vertigo or instability because the vestibular component of it being affected. And it's part of what we call the differential. We have to think of other things. And a large acoustic neuroma, someone asked about that as well, can of course be like a tumor, and it's going to cause headache, pressure in the area, affect multiple neurologic symptoms. So an acoustic neuroma can have some of the same symptoms depending on what it's pushing, okay? But today we're talking about Chiari. And of course, nowadays with our beautiful scans, both CT and MRI, we can find a vestibular schwannoma fairly straightforward. It's the Chiari that tends to be tricky, especially for the general practitioner. There's a typical definition, but what I would say is it's not concrete. In other words, we have to remain open in our minds. But the typical definition is if the cerebellar tonsils hang into the spinal canal 5 or more millimeters, we call that the Chiari malformation. And overall, it's a very useful rule. On the other hand, I could show you a scan of a lady who has 2 millimeters of herniation of the tonsils, yet she's got many of the symptoms that a Chiari patient would have, okay? So in that lady, I did a Cine flow study, a special study looking at spinal fluid flow at the base of the skull, and it was totally blocked. Not only that, but 2 millimeters, she was driving spinal fluid into her spinal cord called syringomyelia. And that's a paralyzing condition. And to summarize this case and close at this point for a moment, I said, you know, you only have 2 millimeters of herniation, but your flow study shows blockage, and you've got fluid driving into your spinal cord, which would mean over time you're going to get paralyzed. So what do we do, doctor? Well, I think we should go ahead and decompress the area, do the surgery for Chiari. We did the surgery, and she had a dramatic improvement, fortunately. Many people improve quite a lot, and there's a question later on about outcome, but it's not 100%. We have to be realistic about that, and we can talk about that some more. But as a way of introducing the Chiari malformation, that's what I would say.
I think you touched on a lot of really great points there. That was a really great introduction, especially into the neuroanatomy, into a lot of the symptoms, and what we as clinicians start to do when we hear the patient and we kind of break down the story and really try to critically analyze the information, because it can be really overwhelming as a patient. And I think you said this, you start hearing these symptoms, and a lot of different conditions can present similarly. And as an patient, when you're going on Google and you start putting in your symptoms, so many of these different things can pop up, and it can be really just almost paralyzing to be like, where do I fit? Where do I fall into? And that's why you go to clinicians such as yourself to really just, for guidance. And so one thing I think I wanted to start with,
Sure.
one thing you mentioned is MRI, or you mentioned the Cineflow MRI. This wasn't one of our questions, but I was hoping, actually, would you be able to elaborate for those listening that have never had an MRI? Would you be able to explain to them what maybe they could expect when they go to get an MRI scan? What is the experience like, or what should they expect going into it? So maybe calm some nerves.
Yeah, I had an MRI about 1.5 years, first time ever. Small little cyst in the liver is all they found. So fortunately, nothing to worry about, but it had been a concern. So I have my own personal experience. It's a small, narrow tube. Okay, that's the first thing. It is not overwhelming for the most part. I imagine if somebody has maybe claustrophobia or whatever, it could be, and you could get sedated. You could get a little Valium or something like that orally. But for the most part, it's comfortable. It can be somewhat noisy, but they will tell you that. So you kind of expect the bangs and the whoops and whatever whistles that this machine makes. What I will say, not only my own experience, but just being in scanners at times when patients are there and watching from the window, the team that puts you into the scanner is wonderful. They're experienced. I tell you, there can't be, they're very caring, and they know what they're doing. So, and if there's somebody learning, fine, there's the more advanced person that's helping them out. So, and really it's a marvelous technology that we have in MRI scan. And the bottom line is, for the neurosurgeon, for the most part, we want to look at the side view. It gives detailed pictures of the brain, and it's important. This is an important aside. You always want to have the rest of your brain looked at. You don't want to be missing something else that could be contributing to what's going on. But the bottom line is, for Chiari, we're looking at the side view in particular, and we can actually, just from the scan, measure. We can see where the hole at the bottom of the skull is. We can put a little ruler, a digital ruler on there, and we can measure the amount of hang down. Again, in general, 5 millimeters or more is defined as Chiari, but we have to be open-minded. And in the past few decades, there's a new type of Chiari. It's called Chiari Zero. Chiari Zero means you might have 2 or 3 millimeters. You don't meet the diagnosis, but you've got all the symptoms and you've got evidence of crowding. So there's Chiari Zero as well. There's Chiari 1.5, which I think probably isn't. I understand why somebody labeled that in the literature, but it's another way of saying a very severe Chiari. So Chiari 1.5 is basically the brainstem is really elongated. The tonsils might be 30 millimeters, for instance. I've seen, that's probably the maximum that I've seen, and it's amazing that people are able to put up with it that long, et cetera. So anyway, those are the MRI is the definitive scan for Chiari malformation. One brief aside, I always get a 3D CAT scan of the skull because people can have bony anomalies. The back ring of the C1 may not be fully closed. If the surgeon's not aware of that, they could get into the spinal canal sooner than they should. So I always look at that area and scan folks with a 3D. It just become routine for me because, it's not that frequent, but if it's 10%, then you're still going to have folks coming in with bony anomalies in association with Chiari.
That's great. That's a really helpful answer. And so I think kind of another question I had from your initial answer you had provided, you had mentioned syringomyelia as an associated condition for some patients, not all, but for some. Would you be able to kind of clarify some of the just kind of the hallmark symptoms, both for Chiari and then but also for syringomyelia, that just as clinicians, what you kind of listen for both conditions that patients should expect?
Good points. Good question. So for many people, Chiari is primarily cranial symptoms in the head, hearing, balance problems, controlling their eye nerves, maybe controlling their facial movements, maybe controlling their tongue movements. Those are all brain-related areas. On the other hand, syringomyelia is fluid building up inside the spinal cord, so we get more of a spinal problems. I'm numb and tingling. My walking is off. I stumble. I have a burning pain in my feet, et cetera, et cetera. So the fibers inside the spinal cord, especially what are called the sensory fibers, where we feel things, are being stretched and damaged, and also the coordination things. So they're going to complain more symptoms down below the head, if you will. And so screening for syringomyelia is quite important. You want to, I mean, there are different tests and different specialists probably do differently, but can they toe walk well? Can they heel walk well? What do their reflexes look like, especially in the knees and ankles? If you hit them and they go like that, then you go, whoa, that's just way out of normal. And then, so I didn't get MRIs of the spine routinely on everyone. I mean, that's a lot of study as well, but you have to be suspicious. And there are a handful of symptoms that make you think, you know, this could be. Now, fortunately, in some, the syrinx can be seen up high from your regular brain scan. But yes, we had a number of questions that we would check to see. And then if suspicious, it's better to be safe, get the spinal MRI and see if there's syringomyelia.
And kind of while we're on the topic of symptoms and looking at the cervical spine, can you talk about dysphagia or swallowing abnormalities? There was a question that was submitted about what the impact of Chiari malformation can have on swallowing ability.
Yeah, so the control of the mechanisms for swallowing are in the lower brainstem. So they dysfunction compression, which is going to be often highest at the top of the whole of the can affect those nerves, the swallowing nerves. So in our practice, and I think many other practices do the same thing, we had a long list of symptoms and check boxes, and folks would check, you know, are you having dysphagia, which is it's the technical term or the medical term for swallowing dysfunction. And, you know, I guess that makes me think of, you know, there are a number of, a classic Chiari patient will have often a cough headache. They don't like to look up, etc. Their head wants to blow off if they cough. They'll have dizziness, vertigo, maybe some balance issues and those kind of things. But you start having greater compression in the upper area of the spinal cord, and you can have increased symptoms.
And once that starts happening to a patient, what are our treatment options?
Okay, it does depend on how they're doing. And, you know, obviously a severe neurologic symptoms that have never been diagnosed, let's say, that are affecting balance, quality of life, severe pain, multiple drugs, et cetera, and they have a Chiari, then, you know, that becomes their main option, obviously. But there are other folks that aren't that bad, if you will. And I had one lady, she had, I think about 6 millimeters, so 1 millimeter over the diagnosis, if you will. And she asked a very good question. She said, what else can I do after I explain the surgery? Well, realistically, she was around 250 pounds. And I said, well, if you get serious about weight loss, you may actually reduce your symptoms and maybe even completely get away from having to have a surgery, because that adds another burden, if you will, to the nervous system. And frankly, that's her, that she says, I'm going to do that. And she stuck with it. It's not easy. I recognize that. And her symptoms dampened down enough where quality of life was good enough that she didn't need to. So we got into habit of drawing up some blood work, especially C-reactive protein, CRP, which is a sign of inflammation, and some other basic labs, just thinking wider than just what we're seeing on the scan. Just because somebody has a Chiari malformation doesn't mean they couldn't have something else, that if we dial that down, those symptoms down, their quality of life might improve enough to avoid the surgery.
Right. And so something I see in my practice too, and you and I discussed, but for those that don't know me, I care for patients with multiple sclerosis. And so I tell my patients this a lot, where just because you're having symptoms, just because you have multiple sclerosis doesn't mean that all of your symptoms are because of multiple sclerosis. Unfortunately, our bodies are allowed to have as many problems as they choose. And so just because you have Chiari malformation doesn't mean that every single problem is because of the Chiari malformation. And so if there's, and you kind of started alluding to this, that we should be more broad. We should check for other things that might be happening in the body. We shouldn't limit ourselves to just the Chiari malformation. Is there anything that you would advise your patients to, basically, if there's anything that wouldn't fit with the Chiari malformation, how would you advise someone to kind of just,
Well, I guess that's a good question.
Yeah, not to limit themselves or just blame it all on Chiari.
Yeah, not fit. You might, direct your studies. Okay, yeah, let me see if I'm understanding you. Somebody comes in, they have headaches, maybe dizziness, a few other things, neurologic symptoms. Somebody wondered whether they have Chiari. I get a scan. They're 2 or 3 millimeters. They're not particularly crowded. They're rounded. A side view shows there's reasonable space of spinal fluid there. And so to be more certain, I'll get a cine flow MRI, which is kind of a grainy side view scan, but it allows us to see how the spinal fluid is flowing. And if they have normal flow, I'm not going to help them, even though the tonsils may be down a little bit. So it does get tricky there. And then you want to start widening your view. One of the upcoming questions is celiac disease, gluten in particular. And, it can cause some of the nausea, vomiting, and those kind of things. That can be either, the vomiting center, by the way, is in that lower brainstem. So it can certainly be brainstem, but it might be gluten neuropathy. So we advise them to consider. We used to, for a while, had a general health nurse within our clinic who would then take over and kind of help them with guidance on, abdominal pain, nausea, weight loss issues, or fatigue issues that might not at all be related to Chiari. It's just somebody saw a bit of a change on the scan, but it just didn't add up to really truly being Chiari malformation.
Yeah, so you kind of read my mind. Was the celiac, there's a question for those in the audience about a possible relationship to celiac disease and other systemic or conditions that affect the entire body, other conditions like that, and if there is a relationship with Chiari malformation or other neurologic disease, or just in general neurologic symptoms coming from diseases that aren't Chiari malformation. And I think Dr. Oro did a great job explaining that sometimes symptoms, although maybe we do have this on our imaging, maybe it's not completely explained by this, and it doesn't necessarily drive the treatment indication. So I think you explained it perfectly well. And so I think that does kind of shift our gear here into what is your specialty here, is do we pursue surgery or not? And what is the deciding factor in how do we choose surgery for someone? What does surgery look like? And so I would love if you'd be willing to explain what
Sure.
does the surgery for someone for Chiari malformation look like?
Sure. And I have several recent presentations online. I don't know, maybe somehow I can maybe email you and whatever and give you those links. That are you still there? Okay. Yes, I've spent a lot of time. Well, as our experience continued to grow over the years, I didn't find Chiari. Chiari found me, okay, way back when. As our experience began to grow, we started seeing folks that had had a Chiari operation, but were doing poorly. And so they would come in. So I started seeing folks that might need a revision surgery, that's something, you know, Chiari sometimes is viewed as a fairly straightforward operation, but in my mind, it's not. Because if it's not done well, then the patient might need another surgery. And that's a tough situation. I've done just over 100 revision cases where either the bony removal was very small and never allowed for the room, or others that go in and do a whole giant amount of bone. And then if the muscles and skin aren't closed, I can push on the back and feel this spinal fluid pocket. Now, I think to just bring this case into view, I will share just the first case I saw like this. And it was a young woman. She was a nurse up on the East Coast, and she was found to have a Chiari malformation, and she underwent Chiari surgery. She did quite poorly, could not go back to school. She went to her neurosurgeon, and his response was, "You're wide open." Okay, I'm wide open. In other words, there's nothing to do. Seeking further help, she found another neurosurgeon in this big city on the East Coast, and he told her and her mother, "You're wide open." So she got depressed, unable to drive, unable to work. I think about 6 or so months later, and I've written about this young woman online, they ended up coming to Colorado. They found our center, and it was the first case like this that I had faced. So it was early on when I moved to Colorado from the University of Missouri. And I have all my patients, their families, see what I'm seeing on the computer screen, showing the scans, okay? So we got some scans, and I showed her the scan. I'm sitting in the center. She was to the left of me. The daughter and the mom who had brought her was sitting to the right of me. And I said, "If you don't mind, can I feel that area?" And she said, "Well, yes." So I took 2 or 3 fingers and laid them on the back of her head. So I'm like this. And I gave a sudden pressure, not deep, but sudden, okay? Maybe 2 centimeters or so. She went, "Oh." Her mother went, "Oh." I went, "Oh my word." Because the only thing covering the spinal fluid pocket was her scalp. The bone had been removed so widely, the muscle tissue was never well closed, and I was feeling that fluid pocket. So while her surgeons had told her she's wide open, my answer, and I've got links to this image. I told the mother, I said, "You're wide, you're too open. Your spinal fluid there's only skin between you and the outside world." Mom says, "Well, what do we do?" And I developed a titanium plate specifically for Chiari patients. And I said, "Well, what I would recommend is a reconstruction of the large amount of bone that was removed, and then closure of the muscle tissues and the skin." I said, I've never done it before. And the amount of bone that was taken, I don't have a plate big enough to cover it. However, I can ask the company that I'm working for, and I take nothing from these companies. I wasn't smart enough, sorry. But no, I just, I mean, it was the right thing to do. So I said, I can ask the company to make a larger plate. And she said, how long did it take? I said, maybe 4 weeks, maybe a little more. She said, we'll come back. And so they made a large plate for me, because with a 3D CAT scan, we could measure exactly how much I needed a plate. So I had them build a plate. She came back for surgery, put the plate on, got the muscle closed, got the skin closed. And the first thing she sent me was her wedding invitation. She went back to work. She sent me her wedding invitation. A couple years later, her first child, and a few years later, her second child. And I still, from time to time, remain very deeply connected to this wonderful family. By the way, she went back as a nurse to the hospital that she initially started at. And every few years now, since it's been some years, every few years now, I might get a little note, maybe something in the mail. So it can be overdone and it can be underdone. And the key thing is, it's often said that it's a straightforward operation. Well, it's not like taking a deep brain tumor from underneath your brain somewhere, okay? But if it's not done right, and that's what my most recent talk at one of the Chiari organizations was about, is why Chiari malformation fails. And among the two reasons, there are a number of them, are too little or too big. It has to fit. Sorry, that I always get a little emotional on that issue, but anyway, there's a lot. Fortunately, we can help many of these folks. Let's put it that way.
No, I mean, that is a beautiful story. That it's amazing to have somebody here sharing the experience and the way that you've touched somebody's life, and I'm sure countless lives. And I really just value what you're sharing today. And I'm really just excited to hear kind of what you're going to guide us on here too, in helping someone decide that this might be right for them and how to kind of safely pursue this. And I think one of the questions is basically, you've touched on it a little bit already and how you kind of make this decision, but how is really the decision made by a surgeon, making sure that somebody's the correct candidate? Is it symptoms? Is it herniation? Is it flow? Kind of what is the decision-making process, and basically what ends up being the final decision in guiding a patient to say, yes, let's do this?
Super. Yeah. So it's probably this group of factors that are flowing in and out, and you're trying to figure out, what's the picture here. So obviously you're going to look at quality of life. Number two, you're going to look at stressors. Okay. I remember one young man who had a Chiari, not terrible, but had a Chiari. And my nurse said, you're not going to help him. And I said, what do you mean? Because she would do the social visit. So I would do the medical visit. She would look at the family situation. Says he's in the basement all night long playing video games, doesn't get involved with friends, etc. And this is pre-pandemic when we could get out. So I was very frank with the family. I said, we need to deal with these. So they weren't doing the parenting job, which is hard. Don't get me wrong. He just had no focus in his life, very disrupted psychologically life, if you will. And so maybe I'm not answering your question, but the bottom line is you've got to be sensitive for those kind of things. And they're rare. That kind of situation that I just mentioned is rare, but there are other things to help that person with. And then if they need Chiari surgery, they're in a much better position to have Chiari surgery. Okay. So we developed the Chiari symptom profile. I mean, it's now being used by a number of other centers. Everybody fills out a Chiari symptom profile. There are a number of questions that give us an idea of the quality of your life. Okay, not just all these neurologic symptoms that I'm talking about, but others, social, can you drive, can you do this, can you do that, and to what scale and what rate. And because we're trying to change the quality of life. So we better measure the quality of life. And then we remeasure it. And we found significant improvement in quality of life in Chiari, in our Chiari procedures, et cetera. So, so that goes into it. The social component, I guess I will call it. That goes into the decision making. Are there other stressors here or not? Are there other ways? Could this headache be something? Yes, they have Chiari, but a lot of people walk around with some Chiari and are doing okay. So just because you see it on the scan doesn't necessarily mean you have to operate, okay? Then we do blood work, which I'm into wellness quite a bit, or became interested in wellness. And if they come out with a CRP, which for the general audience means their body's very inflamed because of the nutrition, et cetera, we need to control some of those things to get them back in line, okay? Because we might not be able to fix everything. And then I guess the final thing is a gestalt of the overall imaging scans, including Cine flow scans if we need them, putting that package together, and then looking at the dysfunction, the severity of symptoms, the impact on the quality of life that they have, and trying to balance that, okay? And it's not a decision that I can make. And I ask them not to make it when they're there, that visit. That I want them to go home, think about it. If there are more questions, let us know, because it's a big operation, it's the bottom line. And anyway, overall, that's been our process, measuring their dysfunction, not only neurological, but social, if you will, and then consent. That's why, in my view, the consent process is very important. And if there are other surgeons that are starting out, what I would say is you take a model of the skull into the room. Yeah, I always keep one there. You show them where the area is. You show them the amount of bone that needs to be taken. You want to empower them some as much as you possibly can. You don't want them to say, well, I never heard about that. I didn't know they were going to take bone off my skull. Well, as a matter of fact, I showed you illustrations at the University of Missouri. I had some very nice illustrations of the back of the skull before and after the bony decompression. So I showed them, and they need to see their scans. They need to be engaged. So in a way, it's not my final decision. I can say whether they're a candidate or not. Yes, you're a candidate. You're having enough symptoms, the findings fit, etc. But you're the decision maker. You have to balance, you have to take time to reflect and decide.
That's a perfect answer. That answered it exactly, I think, what we wanted to hear. And I love the way that you empower patients. I think that's fantastic. I think something that's asked here is shifting gears a little bit into, let's say somebody has pursued the surgery, they've decided it's right for their life after they've had this kind of shared decision-making process, a little bit of the aftercare. So after the procedure, what's the follow-up like with their surgeon? What's kind of the anticipated trajectory afterwards? A little bit of the aftercare process, if you could elaborate.
I think that's great. That's excellent. Yeah, so we developed over time, we developed 4 guides. They're usually 4 pages, so but there's some. So one's sleep, one's nutrition, one's physical activity. The other, I think, is on just general wellness. And so and of course, even myself, somebody gives me all these, I'm not going to make all the changes there, but can they find something in those guides to wellness. One of my last talks was how do you empower yourself following Chiari surgery? What is it you can do to change the quality of your life? But anyway, and there's one of the questions here is that the surgeon doesn't want to see them again, that they had one surgery, everything's okay. What I would say to that person is there are other surgeons, there are specialists. You can look at, went ahead and just kind of searched a few. Mayfield Clinic is very prominent in Chiari surgery, the Mayo Clinic, our institute, the Colorado, I'm retired, so I don't operate any longer, but the Colorado Chiari Institute, the surgeon that's taken that over also is quite experienced. So if your surgeon says you only need one visit, I don't need to see you, but you're still having symptoms, then don't take that as an answer. Then search. It's what I tell people, because every now and then I still get called, hey, do you know somebody on the East Coast or the West Coast or wherever that is a Chiari specialist? And I'll empower them to go online, begin to search Chiari surgeons in the Northeast, Chiari surgeons in the West, or in a certain state, if you will, and pick 3. As you're going to scan a number of candidates or people, surgeons, and pick 3 that then you do a deeper dive into the person and what they are, what their website says. I mean, that's the way you're going to get it, obviously. But if you go visit someone and you're uncertain and you don't feel like you've gotten, oh, I understand this, and this person seems experienced. Frankly, it was a nurse in our hospital, and it was their child who had Chiari malformation. And she and I, at the hospital here in Colorado, I didn't do children. I did at the University of Missouri, but not here in Colorado. And I said, pick 3, okay? And I explained to her how, and then visit them. Because I don't know, you may walk into that hospital and feel like, the floors aren't really clean. These people are a little, grumpy or whatever, right? You're not going to get the feel. So you do want to have some choices to be able to say, or yeah, wow, that was great. And frankly, a lot of medical practices are going to be at a high level, fortunately, okay? But not all. And so you again, early on, go online, find someone maybe in some states surrounding you where you don't have to go across country, but you may choose to, okay? That is there, there's a question about, places to go and that kind of thing. And it's some legwork. Again, I've told people, narrow it, browse, narrow it down to 3. And then you may want to visit, or you may simply say, they're just 2 hours away from my city, and that's where I'm going to go first and get the feel. And did it feel right to you? And ask questions. I mean, come on, I'm a little shy in my doctor's office, but over time, maybe not too shy, but we just got to ask questions, and ask the questions you want.
Right, absolutely. You got to make sure it's a good fit for you. And I absolutely, at least my own patients, recommend second and third opinions. I mean, please find the right provider for you. Make sure it's a good partnership and someone you trust in a place that you feel comfortable in. Yeah, I absolutely agree with that sentiment. So I think something I want to kind of transition to into some of our final wrap-up thoughts here is, so after someone's had the surgery, the concept of symptoms returning. And what I kind of want to pick your brain about, no pun intended, is if symptoms are coming back, what is driving you into being concerned that someone needs a revision procedure versus this is just maybe where someone's going to be at, the procedure kind of did what it could, but this is what they're going to be left with, first red flag versus we kind of, it wasn't curative. What I'm kind of trying to get at here.
A good question, because it helps me expand into some other things that the surgeon treating Chiari has to be aware of. And I'll just focus on, well, there's one that's called tethered spinal cord. So is it a hidden tethered spinal cord with a Chiari? And so you want to listen to symptoms in the lower body in particular. So drawing a blank here for a second. Rephrase your question just briefly. Sorry.
I can actually break it down. Let me split it into a question here. Let me start by saying, if someone's had a procedure, what symptoms should they be concerned about that are like a red flag that they might, something might be wrong, that they need to see their neurosurgeon, and they potentially could even need a revision?
Well, I mean, it's return of some or maybe all of your symptoms. I'm still having dizziness. I have a cough headache. You know, I still have numbness. I have tingling. My gait is off, et cetera, et cetera. And then, yes, then they come back in. And this is actually the patient. I think of the patients often as that have come in that have already had an operation. They're obviously made the trip because they've got things ongoing. So I have to ask myself, all right, what is the bony decompression like? I better get a 3D CT scan and I'll know it, and we'll all be able to see it right away. And as I was consulting on a case right now, as I was saying, if you walked into a home that was just built for you, or a new home or whatever, we all know what doors look like, right? I mean, they look like that. I mean, that's fairly straightforward. But what about if it looked like that? Okay, very irregular. Okay, which is a current case that I'm evaluating right now. I'm not treating, I'm just been asked for an opinion. And so it's this small amount of decompression that never allowed so if somebody is not doing well, that person wants to verify that there's space behind the tonsils. If I'm the patient, I want to see again my before scan, a side view. I want to see my after scan. Can you show me where you made some space? Well, there's this little bit here. And there's going to be an intuitive sense of kind of like, well, that doesn't really look like a lot, does it? Can you tell me how much bone you removed? Oh, you know, I take a little here and a little there. Oh, could you get a 3D CAT scan so I can actually see how much bone you removed? So you are advocating for yourself. Now, again, specialized neurosurgeons, there's a pocket of UCLA, New York, our center for a while that specializes in revision surgery. So they're going to sit down and show you why it failed, which is another way of thinking of this question is. And again, is the wound well closed or is it sunken in and there's no support? A lady that I saw from Santa Fe, she couldn't hold her head up. Well, the muscles were never really closed together properly, et cetera. So you want to see your scan after surgery, and then you get an idea. You might, if you want to be sophisticated about it, you might ask the surgeon, how wide was the hole at the bottom of my skull, the foramen magnum, right? How wide was it? Oh, it's about 32 millimeters in the average adult. How wide is mine? Yours is 19 millimeters. Oh, doctor, why didn't you take off enough bone? Oh, gosh, I didn't really understand that. I mean, again, I'm being a bit harsh, and most Chiari surgeons do quite well. But having become specialized in revision surgery, failures start with poor closure of the wound. And that, unfortunately, might be that the surgeon walks out and lets the resident close the wound. Now, I don't know that for a fact, but that can occur. And a talented resident who's been well-trained should be able to close the wound. But to have these sunken in wounds that they're not going to support the head. So it's questioning about why is my wound feels great or it doesn't. I'd like to see my scan. Why is it so irregular? Okay. Doctor, do you think it fits for my Chiari, or was it simply too much? I mean, I've seen decompressions, they're so wide, it's sad. One university woman, she's one of these technologists, has some kind of online business, and this has been a few years ago, so it was before most of us knew how much was happening online. But she works like this on her chair that is supported because she can't hold her head up because things weren't closed well. Okay. So anyway, maybe I'm getting a bit too nitty gritty. Most of the time, and I'm hoping over time, the consensus and the approach, since there's so many people lecturing on this way beyond myself, that I think a lot of the Chiari surgeries are indeed done well and improve quality of life significantly and dramatically in some cases, and good in many other cases. But question, advocate for yourself, search for specialists that have worked with Chiari. If your first Chiari surgery didn't help, go to some of the meetings of the Chiari organizations that are set up for patients. Learn, talk, advocate for yourself, and then also on your end, the patient's end, is how's your sleep, how's your physical activity, how's your diet, how's your emotional health, because all of those things, or if some of those are off base, we don't do well. Anyway.
No, that was the perfect answer. And I think just for we're pretty much about that time, and that was, I think, the perfect conclusion that you could have provided. The last thing I wanted to request of you, we had a request just for our patients listening. Do you have any recommendations for our patients kind of in just like the general West Coast, East Coast, kind of southern regions, where to kind of start their look if they're looking for a center or just somewhere you would trust to kind of start their look for resources, surgeons, for just general areas?
You see on the West Coast, UCLA, University of Washington, up on the upper East Coast, on the West Coast, I'm sorry. I mean, you've got, your Mass General, you've got your Johns Hopkins, Miami. So there are a number of different specialists. Obviously, they change over time. I think what I would say is, when at all possible, join one of the Chiari patient organizations. They're highly devoted to caring for those and the families of Chiari patients.
That's fantastic. Just again, I cannot thank you enough, Dr. Oro, and for everyone in the audience who tuned in tonight. On behalf of myself and the entire Chiari Project, we just wanted to extend just a sincere thank you for joining us tonight and for everything you've done, the education you've provided. We are so appreciative of everything you've offered tonight. And for everyone listening, we do have another one coming up. I do see that some participants have entered questions in the chat. And I want to encourage you to email those questions to amanda@chiariproject.org so we can address those questions at our next Q&A session. But for otherwise, that is all we'll have this evening. Thank you once again, Dr. Oro. It was a true pleasure.
Thank you, Leslie.
All right.
Oh, it's a pleasure. Yeah.
All right.
A host like yourself, very important to this movement. So congratulations and thanks to everyone.
I appreciate it.
All
right.
Thank you.
Have a good night, everyone.
You too.